Good evening to everyone present here. I'm Rudrakshi Shetty, the Joint Secretary of ThinkMED and the moderator for today's session. I welcome you all to this amazing session by ThinkMED. And we would like to welcome you, and it takes us great pleasure and enthusiasm to welcome today's webinar on emergency medicine. I'm honored to introduce our esteemed guest, speaker, and an exceptional physician who has made significant contributions in the field of emergency medicine. Our guest speaker is renowned for their expertise, experience, and unwavering commitment to providing exemplary care to patients in times of crisis. Spanning numerous years, they have emerged as a respected leader in emergency medicine, playing a pivotal role in advancing this critical specialty. Beyond their clinical prowess, our guest speaker has actively contributed to research and pushing the boundaries of medical science, pioneering advancements that save lives. Their groundbreaking work has been recognized internationally and has garnered numerous accolades and awards. So, has completed fellowship programs with Physicians London, Edinburgh, and Glasgow. It is my sincere hope that this webinar serves as a platform for meaningful dialogue and knowledge exchange, fostering collaboration and inspiring us to continually improve our emergency medical services. Let us extend our warmest welcome to our distinguished guest speaker, Dr. Haider Abbas, who has expertise and insights which will surely enlighten all of us and inspire us all. Please join me in giving him a round of applause. Thank you so much for your time, sir. You may take over.
Thank you. Good afternoon to all of you. Thank you, ThinkMed, Dr. Vaibhav, Dr. Dakshi, for the good introduction. Thank you, ThinkMed. Today is we are going to discuss about approach to a patient of poisoning in emergency room. Basically, we know that poisoning is a global public health problem. Based on the WHO Health Organization data in 2012, almost 190,000 people died worldwide. The number of deaths due to poisoning exceeded the number of motor vehicle crashes in 2008. So this is the pictorial representation of various poisons which we see in KGMC and elsewhere. Like this is Divox, this is Malathion, this is IPL 505, which is a mixture 50-50 mixture of uh, chlorpyrifos and cypermethrin. This is aluminum phosphide sulfos poisoning, which is a rat kill poisoning. This is rat shoot, rat kill zinc phosphide. This is dimethoate or coming in a commercial form of Rogo. These are the various poisons we normally see at KGMC. There is a pesticides, pyrethroids, OPPP, and pyrethroids, phosphide, paraquat, alcohol inebriants, and others like paracetamol, phenobarbital, and copper sulfate. So, what is poisoning? Poisoning can be accidental and poisoning can be intentional. So, according to Lindsay Murray, acute poisoning is a dynamic medical illness, usually representing an acute and potentially life threatening exacerbation of a chronic underlying psychosocial disorder. Poisoning may be local or systemic depending on the chemical and the physical properties of the poison, its mechanism of action, and the route of exposure. So, when to suspect poisoning? We actually come across cases that when it's really difficult to find out the patient has taken a poison, whenever there's a history of ingesting something, unexplained symptoms, no obvious cause, history of psychiatric illness, history of recent declaration of exam results, history of discordant relationship at home, or a recent change in behavior. We frequently come across patients, attendants, parents in which the kids have taken some ballpoint ink, bubble soap bath, chalk, cigarette butts, crayons, deodorants, lipstick, pencil, toothpaste, and they ask us that whether it is toxic or non-toxic, then it is actually they are actually non-toxic. Modes of entry: ingestion, instillation, inhalation, and injection of various drugs like opioids. Regarding poisoning and approach to poisoning in emergency room, we must understand that resuscitation is the key. Resuscitation gives us time so that we can do risk assessment and treatment and subsequent disposal of the patient. Many patients will recover with simple supportive measures. We need to alleviate the anxiety of family members, reassess the patient regularly because symptoms may recur, encourage the family members or friends to bring whatever remnant poison is present in the family or in the vicinity. All cases do not require a tertiary care like KGMU. Toxic manifestation may appear later. It's ideal to observe for 24 to 48 hours. Every poison case is different from others. Treatment is more important than finding the causative agent. Approach, as already said, it begins with resuscitation, and among the golden rule number one, resuscitation is the key because control of airway, breathing, circulation itself gives us enough time to further formulate our risk assessment strategy. And if ABC is okay, the patient is not going to die and will definitely give us time for evaluation. Then the supportive care and monitoring, investigations, decontamination, enhanced elimination, antidotes, and disposition, which we will discuss later. Resuscitation, there is always endless discussion about resuscitation and resuscitation science in emergency medicine. It always begins with airway, breathing, circulation, disability, and exposure. If the patient is talking, then the airway by definition is good. If the patient is not talking, the patient is not able to phonate, patient is in a cardiac arrest or a respiratory arrest or a threatened airway like GCS less than 8, then you assume significant airway obstruction and we need to get emergent airway control because airway is the key. If their air is not going in, patient will die within minutes. So this is the pictorial representation of tongue falling back and causing airway obstruction. Breathing comes next because it will kill next. After ensuring adequacy of the airway, look for evidence of respiratory distress like tachypnea. Use of accessory muscles looks for abnormal asymmetrical chest wall movement because after poisoning, patient may have fell down and may have caused any injury. Give oxygen, intubate or ventilate if required. Circulation is very important because as we know that if the patient is in shock, cold clammy skin, altered sensorium, we need to put 2 large bore IV cannula. This is the rule, followed by flute challenge, resuscitation, and if shock is not resolved, then use of inotropes. These are various mnemonics for the hypotension like crash, calcium channel blocker, reserpine, antidepressant, sedative, and heroin, bradycardia, propranolol, acetylcholinesterase, clonidine, ethanol, and digoxin, tachycardia, cocaine, theophylline, and anticholinergics. After resuscitation, then immediate reversal agents can be tried before decontamination. That is naloxone, which is a opioid antagonist, 2 milligram in adults, zero point 0.1 milligram per kg in children for severe respiratory depression. IV dextrose should be given because patient might have vomited for a long time and might have not taken anything by mouth for a very long time. So 50 ml of 50% solution for adults, 2 to 4 ml per kg of 25% solution for children should be given. Then thiamine is a very important. 100 to 300 milligram IV is given with or before dextrose to adults with suspected thiamine deficiency. Example, prolonged vomiting, alcoholics, malnourished patient, vernix encephalopathy can be precipitated. IV fluids are given for hypertension. Normal saline 20 to 30 ml per kg is advisable dose in hypertension. If no response to adequate fluid resuscitation, start NORAD infusion. Risk assessment is very important. Are you able to see my slide? Are you able to see my slide?
Yes, sir. Yes, sir.
Risk assessment, history, examination, toxidromes, and diagnostic testing. History. The limitations in the history is that the patient may not have a clear history due to psychiatric illness or altered sensorium because of fear of arrest by prosecutors or repercussions from family or friends. Informations include identity of substance, doses, and route of exposures, crucial in formulating a risk assessment. Obtain collateral information from family, friends, or previous medical records if available. Pre-hospital emergency services can provide in some information from the scene, like some particular smell, particular materials or substances present. If possible, obtain knowledge of hobbies, occupation, presence of a suicide note, or recent change in patient behavior. These are the examinations to be done. For example, general appearance, dress, or signs of injury. If the patient is unkempt, it suggests psychiatric illness, or signs of injury, example, scalp hematoma. Odors like bitter elements, cyanides. If the garlicky smell, organophosphorus. If the fruity smell, alcohol. If the fishy smell is zinc phosphide. If it's a smoky smell, the possibility of carbon monoxide could be there. Then in the CNS, conscious state or meiosis like opioids, OPP, phenothiazines, and clonidine. Mydriasis is seen in datura, alcohol, carbon monoxide, cyanides, nystagmus in anticonvulsants, and ethanol toxicity. You know that the thousands of poisons are available, and these smell, this pupillary signs, the dress, the attitude, everything may give some clue about the possible poison. Cardiac means if the patient has got a hypertension or a hypotension or tachy or brady, then this is the list of poisons which can be suspected. Like in hypertension, amphetamine, cocaine, nicotine, hypotension, diuretics, ethanol, calcium channel blockers, Datura, salicylates, nicotine, bradycardia, opiates, digitalis, and organophosphorus. Urinary color can also be important, like urine, if it is brown, it suggests methyl dopa, myoglobin, or aniline. Black, naphthalene, phenol, or cresol. If it is green, then it's green or blue, it suggests copper sulfate, methylene blue. If it is red, it suggests phenytoin, rifampicin, or desferoxamine. Gastrointestinal oropharynx or abdomen, urinary retention in anticholinergic toxicity, oral cavity burns in corrosive ingestion, hypersalivation in cholinergic syndrome, peripheral nervous system like reflexes, tone, fasciculations, tremor, clonus, they suggest some particular toxicity like lithium toxicity causing tremors, lead pipe rigidity in neurolept malignant syndrome, clonus or hyperreflexia and serotonin toxicity. Dermatological, skin is a big organ. Dermatological or peripheral, bruising, cyanosis, flushing, dry, moist skin, injection sites, bully, they suggest bruising, flushing, coagulopathy, trauma, and coma. Then another approach which can be tried, because with thousands of poisons, they cannot be enumerated into um, various groups, and they cannot have a separate protocols. They then we can use a toxidrome approach. Toxidrome means toxic syndrome means toxidrome. This term was coined by Moffensin and Greenshare in 1970. There are set of symptoms or signs which indicate that the patient has taken a peculiar group of possible toxin or drug, like some CNS toxin, ophthalmic signs like pupil size, GI signs like peristalsis, dermatological like dryness or diaphoresis, sweating, mucous membrane moistness or dryness, genitourinary symptoms like urinary retention or incontinence. So, as we know that toxidromes, there are 5 or 6 major toxidromes. One is anticholinergic or atropine-like toxidrome. Atropine effects, as we all know, you must all be knowing from pharmacology that it can cause tachycardia, fever, hypothermia, mydriasis, dilatation of the pupil, warm, dry skin, causing synonym like mad as a hider, blind as a bat, red as a beet, hot as a hair, and dry as a bone. The common causes are atropine, belladonna, datura, scopolamine, antihistamines, mushrooms, psychoactive drugs, and tricyclic antidepressants. Tricyclic antidepressants have got a different, they are widely prescribed, and they cause some dryness in the mouth. Then the cholinergic, which is the organophosphorus, muscarinic symptoms. The mnemonics are sludge, salivation, lacrimation. In basically cholinergic, what does it mean? That the fluid is oozing from all part of the body, like salivation, lacrimation, urination, defecation, GI cramps, emesis. And similarly, another dumbbells like diarrhea, urination, meiosis, bronchoria, bradycardia, and bronchoconstriction, emesis, lacrimation, and salivation, and other signs. And the causes are organophosphates, most common, carbamates, followed by some physostigmine, pilocarpine, pyridostigmine, then mushroom. Cholinergic, as you know, they work on both nicotinic and muscarinic receptors. Nicotinic, you can remember the signs, symptoms by Monday to Sunday, like Monday, mydriasis, Tuesday, tachycardia, Wednesday, weakness, Thursday, tremors, Friday, fasciculations, Saturday, seizures, Sunday, somnolence or sweating. Common poisons are black widow, spider bites, organophosphorus, nicotine is rare, and carbamates. Then this opioid, the prototype opioid is morphine. So any symptom like morphine is an opioid. What are the available agents? Are diphenoxylate, fentanyl we commonly use, heroin, methadone, morphine, pentazocine or fortrin, which we used to use earlier, but not now, propoxyphene, oxycodone, and hydromorphine. They cause hyperventilation, hypertension, meiosis, sedation, possibly hypothermia because of decreased BMR. Then there is a symptomatic toxidrome, which causes like the most common symptomatic is amphetamines, ephedrines, theophylline, caffeine, cocaine, ecstasy, causing tachycardia, hypertension, mydriasis, agitation, seizure, diaphoresis, hypothermia, psychosis after chronic use. Then this another toxidrome I have added, which is the withdrawal toxidrome. Basically, alcohol and drugs, if withdrawn, can cause a toxicity-like feature, presenting symptoms of diarrhea, goose flesh, lacrimation, hallucination, cramps, yawning, and seizures. Investigations, we are going to do investigations like we are going to do complete blood counts because patient might have aspirated, patient might be having sepsis. LFT are to be done. For example, in paracetamol poisoning, LFT is important. RFT is important because any toxin causing myoglobinuria can cause raised mm, urea and creatinine. ABG, like methyl alcohol poisoning, it can cause high NN gap metabolic acidosis. Chest X-ray for aspiration or ARDS. ECG for QT interval. Toxic screens, qualitative, and drug levels, quantitative. Then after doing resuscitation, doing after resuscitation, once you have got time, you did risk assessment. In that, you have done history taking, examination, and possibly zeroed onto some toxin through toxidrome. Then the role comes of decontamination. So what is decontamination basically? Decontamination means whatever poison has been taken or it is on the surface of the body need to get rid of that poison. So comes the topical decontamination. As you know, that thorough cleaning of the body of the patient, including the eyes, exposed to a toxin with large amount of water or saline, because large amounts may accumulate on the skin because of vomiting or spillover while drinking, because mostly the toxins are taken with some inebriant like alcohol. Therefore, patient frequently spill over the toxin over the clothes, over the body, or they have vomited. So contaminated clothing should be removed and preserved for MLC purpose. Plus, decontamination or topical decontamination reduces the chances for secondary contamination to the healthcare workers. Eye exposure may require local anesthetic installation in lid retractors to facilitate copious irrigation with crystallite solution. Alkalis produce greater injury than acids due to deep tissue penetration via liquefaction. Prolonged irrigation may be required. 10 minutes after irrigation, this is for the theoretical purpose of those who are giving Viva or attempting MCQs, like allowing equilibration of crystallite and conjunctival sac pH. Conjunctival sac pH is tested. Irrigation continues until pH is less than 7.4. This is the ocular decontamination, and this is the topical decontamination. Decontamination, we have done topical decontamination, ocular, then patient has already taken anything by mouth, then we need to do a gastric lavage. Why gastric lavage is important? Gastric lavage is ideally should be attempted within 1 hour of a life-threatening ingestion. But sometimes there are sustained release preparations. For example, propranolol has a beta cap SR, sustained release preparation. In that, we can even attempt gastric lavage even after 1 to 2 hours, up to 6 hours. Or the patients having Parkinson's disease, they have echinacea. In that, we can attempt gastric lavage even after 4 hours. So large tube of more than 36 to 40 French for adults or 20 to 24 French for children is used so that tablet fragments can be removed. Patients should be kept in a left lateral decubitus position. You will be saying that left lateral decubitus position is always preferred because it's the ACLS recovery position. But in toxicology, the reason is different because the pylorus point upwards in this orientation, so that whatever gastric content is there will remain in the stomach and will not pass forward into the from the pylorus and the duodenum or the small intestine. Basically, gastric emptying time is 1 to 1 hour, 1.5 hours, and after that it passes on to the intestine, which is the where the major absorption occurs. This position theoretically helps prevent the xenobiotic from passing to the pylorus during the procedure. For gastric lavage, tap water is infused and withdrawn from the stomach via the same tube. It's a brutal procedure and requires patient cooperation. If the patient is unconscious, it should not be attempted unless airway has been secured. Then after by gastric lavage and removal of tablet or fragments, whatever is there, we can use activated charcoal. What is activated charcoal? It's basically a carbonaceous material, burnt carbonaceous material, which has got a high absorptive area, like 3000 meter square per gram. It is given in a dose of 1 to 2 gram per kg body weight. It's given as a slurry in water or soft drink or juices because it is non-palatable. It's difficult to take with plain water. It should be carried out as soon as possible within the first hour of ingestion. Time release preparation can be given up to 6 hours, what I was talking about. It can remove toxin from the stomach and decrease toxicity level. These are the various drugs and phytotoxins which can be removed by charcoal, like a huge list: ACE inhibitors, amphetamines, anti-epileptics, antihistamines, aspirin, salicylates, atropine, barbiturate, basically a long list. And among phytotoxins like amatoxin, which is known as death cap, aconite, colchicine, ergotamine, ibotenic acid, nicotine, ricin, strychnine, taxinus, digitalis, and yellow oleander. You may have heard name of yellow oleander, which is also known as, in Hindi, it's known as kaner kapul, which is found near the railway tracks or near the highways. Kaner kapul, it's a yellow oleander poisoning. Now, sometimes some people use activated charcoal with some cathartic to facilitate evacuation of toxic substances. Commonly used cathartics are magnesium sulfate, magnesium citrate, sodium sulfate, sorbitol, but we are not using it at KGMU. Toxins which cannot be removed by activated charcoal or insufficiently absorbed. Basically, some people have used mnemonic like charcoal is not absorbing charcoal, but to keep it simple, I'm talking like alcohol, inorganic acids, heavy metals, organic solvents, acids and bases, and cyanides. They are not removed by activated charcoal. So what else? We have done gastric lavage. We have done. We have used activated charcoal. Then and still the poison has passed down in the small intestine. What can be done now? Whole bowel irrigation is done. The other areas of clinical practice where you will see whole bowel irrigation is in radiodiagnosis, is in gastromedicine, where you will see whole bowel irrigation for colonoscopy, endoscopy, and for hemicolectomy surgery. But here it is in toxicology, there's a use of PEC solution, polyethylene glycol solution, is used to wash out the entire GI tract. Polyethylene glycol electrolyte solution helps in purging the toxin before absorption occurs. It is isosmotic, is not systematically absorbed, and it will not cause electrolyte or fluid shifts in the body. So this can be attempted, and this is given till the rectal effluent is clear. Similarly, the indication in gastromedicine is that if the rectal effluent is clear, the consultant can do colonoscopy. After attempting gastric lavage, charcoal, whole bowel irrigation, still we the patient is not in a good shape, we can use some enhanced elimination techniques. These are multi-dose activated charcoal. As we have seen that we gave charcoal in a dose of 1 to 2 gram per kg body weight. Other option is urinary alkalinization, extracorporeal removal, which can take in one of the three forms like hemodialysis, hemoperfusion, or CRRT. CRRT basically used in patients who are sick and have got a very low blood pressure. Multi-dose administration of activated charcoal, toxins are primarily eliminated even in distal sections of the gastrointestinal tract. Moreover, repeated administration is effective against substances that stay in the stomach for longer time. Multi-dose administration of activated charcoal can still be started more than 1 hour after ingestion. In this, after the initial dose, there's a dose of 12.5 gram per hour in adults and zero per kg per hour in adults and 0.125 to 0.25 gram per kg body weight in children at successive intervals of 1, 2, and 4 hourly. Indications for multi-dose activated charcoal. The definite indications for multi-dose activated charcoal are carbamazepine, codeine, dapsone, phenobarbital, theophylline. Digoxin. We sometimes see digoxin toxicity in uh, our emergency. Slow release quetiapine, amatoxin, colchicine, acceleration of elimination. These are relative indications like ASA poisoning, acetylsalicylic acid, amitriptyline, phenytoin, sotalol, peroxicam, lamotrigine, oxycarbamazepine, and salicylate, venlafaxine, and citalopram. Another way you can try is alkaline diuresis. Basically, alkaline diuresis can be done by making a solution of 1 liter of 5% dextrose. Normally, we get a bottle of 500 ml, 1 liter of 5% dextrose with 100 milliequivalent of soda bicarb, along with 20 to 40 milliequivalent of potassium. Because as we know that sodium and potassium have got an inverse relationship in the body, can be given at a rate of 10 ml per kg per hour in adults and 2 to 3 ml per kg per hour in children. Urine pH is kept at 7.5 to 8 and thus potassium must be replaced. Hypernatremia, alkalemia, and fluid overload may occur but are usually not serious. However, alkaline diuresis is contraindicated in patients with renal failure. The main indications are salicylate poisonings and phenobarbital poisoning. Salicylate poisoning, as we know, is very is basically response to alkaline diuresis. This is charcoal hemoperfusion. In charcoal hemoperfusion, there is a need for dialysis machine. Blood passes through charcoal fit cartridge through a special membrane, and the process is same as that of dialysis. It rapidly lowers plasma drug levels, rapidly improves patient condition. Dialysis is a solution for many problems like anti-epileptic drugs, barbiturates, gabapentin, pregabalin, lithium isoniazid, salicylates, theophylline, caffeine, carbamazepine, methanol. We have seen 2 or 3 disasters of methanol poisoning in our emergency complex and trauma center KGMU. Metformin, methotrexate, ethylene glycol, ethambutol, sodium valproate, and salicylates. These all are dialysable toxins. There is a mention in ACLS guidelines about intravenous lipid emulsions. Basically, they are used for local anesthetic toxicity and other lipophilic drugs like diltiazem, verapamil, beta blockers, psychotropic drugs, quetiapine, sertraline, tricyclic antidepressants, and haloperidol. Chlorpromazine and flecainide. Basically, 20% intralipid emulsion is normally available in ward, and it can easily be given 1 to 1.5 ml per kg in 1 minute. Repeat once more, and in case of cardiac arrest, given every 3 to 5 minutes for 3 doses in local anesthetic toxicity, followed by infusion. So this is even mentioned in ACLS guideline. These is a tabular representation of various antidotes which You can select like paracetamol, N-acetylcysteine, anticholinergic, physostigmine. You know, we have got two drugs. One is physostigmine and one is neostigmine. Neostigmine is commonly used in anesthetics, but since it is a quaternary compound, it will not cross blood-brain barrier. Therefore, anticholinergic toxicity, physostigmine is used and not neostigmine, because neostigmine will reverse the peripheral effects, but not the central effects. Benzodiazepines, flumazenil, which is available in India and our place now. Botulism, antitoxin, beta blockers, glucagon, calcium channel blockers, calcium gluconate, carbamates, atropine, because we know that carbamates are also organophosphorus like poisons. They are categorized along with organophosphorus, but in this preridoxime is not effective. Therefore, only atropine is the answer. Snake bites, we know, polyvalent ASV, cyanide, sodium thiosulfate, hydroxycobalamin. Similarly, digoxin, glycoside, digitalis, digoxin specific fat fragments, these are not available in India. Ethylene glycol, methanol, fomeprazole. Similarly, this is another list of antidotes. Like for opioids, we use naloxone, which is now available. This is organophosphate, atropine, and palm. As I mentioned earlier, that palm is not effective in carbamates, therefore it's not given. Only atropine is given. Though the toxidrome is the same, therefore palm is given in organophosphorus. Sulfonylureas, IV dextrose, methotrexate, leucovorin or folinic acid. Isoniazid, as we know that isoniazid is a INH. INH toxicity, the we can use vitamin B6, that is pyridoxine only. Iron desferoxamine, ionizing radiation, potassium iodide. One important thing after doing after discussion of the poisoning, the toxidromes, the resuscitation, the elimination procedures like gastric lavage, whole bowel irrigation, charcoal, multi-dose activated charcoal. The important step is disposition of the patient. Patient must have taken poison either intentionally or unintentionally. If intentionally, patient needs to be seen by a psychiatrist, needs to be admitted to an environment capable of providing an appropriate level of monitoring and supportive care. Options include observation in the ED, ward environment, HDU, ICU care if required. Final disposition depends on psychosocial assessment, which should be organized early in the patient management. Thank you so much. Thanks, Think, ThinkMED, for giving us an opportunity to present a lecture. Thank you all. Thank you so much.
Thank you so much, sir, for this wonderful presentation. It was really, really interesting, especially Monday to Saturday, Wala mnemonic for cholinergic toxidrome. Very interesting. Thank you so much.
Thank
We
you.
have some questions from our participants, if you don't mind answering them.
Okay. Okay.
The first question is emergency medicine. As we know, it is very different from other fields because
Hmm.
sometimes doctors may have to think, may have to act before they even get to think of a proper diagnosis. So, for someone like an intern or a resident who is starting with emergency medicine, what advice would you give for to them?
As I told you during my lecture, that first and foremost is resuscitation. Emergency medicine is all about resuscitation and stabilization of the patient.
Mhm,
Ideally, emergency medicine should hold over patient for only 4 hours, 6 hours, 8 hours, till the forward flow is there and patient is transferred to different wards. So the key in
mhm,
emergency medicine is resuscitation. Take control of the airway, breathing, circulation. Look on the disability, neurological disability, and exposure by time, so that you can do further risk assessment, can get a
mhm,
proper sample history, can do proper examination and further evaluation and lab tests. So key is resuscitation. One of the golden rule in emergency medicine is resuscitation. This will buy time and you can carry forward with your evaluation, be it hematological case like severe anemia. In
mhm,
that, you have to do resuscitation. You need to oxygenate the patient till proper workup is done, like in
mhm,
trauma, like in pancreatitis, like in poisoning, or anything. Resuscitation is the key. Therefore, resuscitation also, or the resuscitation science also. Now, as for from this session, we are going to start postdoctoral certificate course in resuscitative emergency medicine. So entire focus
Okay.
will be on resuscitation and resuscitation research.
Oh, okay, okay.
Yeah,
So how
yeah.
would that be different from emergency medicine residency? Like
Emergency
what
medicine
extra?
residency is a 3 year residency. Is a
Mm-hmm.
3 year residency with a proper curriculum. At the
Mm-hmm.
moment, we don't have any curriculum from NMC. What we are following curriculum from the DNB or NBE, National Board of Accreditation. That
Mm-hmm.
curriculum is being followed for a 3 year period, whereas PDCC is a 1 year course in which
Mm-hmm.
um the trainee will work in the screening area and the triage resuscitation area, and will focus entirely on resuscitation and early stabilization and acute treatment, and will work in emergency ventilatory unit, and will also do some resuscitation research.
Understood. Thank you.
Yeah, yeah.
Uh, our next question is, since today's topic was poisoning, sometimes chronic poisoning may not have the very typical symptoms that we see in acute poisoning, and there may be chances of us misdiagnosing or underdiagnosing the patient. How can we prevent mistakes like these, in your opinion?
How do you prevent what?
Like in chronic poisoning, like in acute poisoning, we know there is some history that will give us a clue for diagnosis, right? But in chronic poisoning, we may not have that history, or the symptoms may not be very apparent. So
Yes, yes.
how can we properly diagnose in a
In
situation?
chronic poisoning is basically seen in cases of like alcohol, or like opioids, or like lead
Lead.
poisoning, something lead poisoning. Lithium poisoning, patient is on mood stabilizer. So in that case, basically the patient ABC are okay. Okay, patient ABC are okay. Resuscitation is not done because his patient is fine. The only thing is that we have to go for risk assessment. Again, the same protocol like history taking, like examination and further workup and toxicological screening.
Okay,
Yeah.
understood.
Some centers toxicological toxic screen is available. Some centers toxic screen is not available. Then we may have to refer the samples to a higher center.
Correct. Agreed. Thank you so much. That is very informative. Session on a vote of thanks, and I would
Thank
like
you
to
so much.
start with you, obviously.
Mhm.
I would like to thank Dr. Haider Abbas, sir, once again for his time and this wonderful session. It was really insightful, and I'm very sure participants learned so much from today's session. I would also like to thank our team of ThinkMed for such a successful session. And we will be having such sessions again in the future, so please stay tuned. And I would also like to thank our participants for their time and attention and all the lovely questions. Thank you so much again.
Thank you, all of you. Thank you, ThinkMed team. Thank you, Dr. Vaibhav, Dr. Shetty, and all of you. Thank you so much.
Thank you
Have
so
a
much.
good evening. Thank you.